Today we will discuss various practical difficulties. First, we'll discuss about the trigger failure, why trigger fails, how to identify, what are the causes, and what is the remedy, how to manage trigger failure. The highest reported failure rate for the GnRH agonist trigger is 3.5%, whereas the SCG trigger failure is 3.1%. So there is hardly any difference between incidence of agonist trigger failure and SCG trigger failure. Although most of us believes that agonist trigger fails too often. How to identify and how to anticipate the trigger failure? When you are doing OM pickup, the aspiration attempts should be abandoned and patient should be re-triggered with the SCG once you fail to retrieve oocytes from initial 6 or 7 aspirated follicles. So in our center, it is always a protocol that whenever the first OCC complex is seen, the embryologist notify and inform us. We always wait or we stop and we wait for the signal from the embryologist after aspiration of 3 to 4 follicles and sending to the embryologist for scrutinization. Suppose this happens, is there any way to anticipate whether agonist trigger is likely to fail or not? 8 to 13 hours after the agonist trigger, if you measure serum LH and serum progesterone, if the value of LH is more than 15 international unit and progesterone more than 3 nanogram, this level is considered as a threshold between what was considered to be an adequate versus inadequate response to the agonist trigger. If both the LH level and progesterone level more than 15 units and 3 nanogram respectively, you can proceed with the oocyte retrieval as originally scheduled. Otherwise, patient should be re-triggered with the SCG and oocyte should be retrieved 36 hours after the re-trigger. What are the causes of agonist trigger failure? There are several risk factors associated with the increased chance of agonist trigger failure. What are those? Low baseline LH, low BMI, high total doses of gonadotropin consumption for control ovarian hyperstimulation. It has been seen that the failure rates are twice as high among the patient when the baseline LH was 1 to 2 milli-international unit per ml and much higher, approximately 13%, among the patient where the baseline LH was less than 1 milli-international unit per ml. The findings suggest that There may be some level of hypothalamic pituitary hypofunction among these normo-ovulatory patients. The additional risk factor for GnRH agonist trigger failure may be a long-term use of oral contraceptive pills before the treatment. So this was about agonist trigger failure. Many times when we advise beta HCG 12 to 14 days after the embryo transfer, then the beta HCG level sometime comes very low in the range of maybe 20, 30, 40. So patient as well as clinician both are tense about the prognosis of the pregnancy. Is there any way to judge the prognosis whether this pregnancy is likely to continue or not? So we commonly do a repeat beta HCG after 48 hours, and if that level doubles up, then at least we have reasonable assurance that this pregnancy is likely to grow. There is another way of judging in a single sitting. The low E2 level on the cycle day 28. In case of low HCG level, was associated with the poorest pregnancy outcome. None of the viable pregnancy occur if the E2 level was less than 100 picogram per ml on day 28. So this is one of the important tool where we can judge the prognosis of the pregnancy when the beta HCG is low. When we are doing transvaginal sonography in infertility cases, the adenomyosis is a very common finding. So we must understand how adenomyosis affects the fertility and what is to be done. The uterine myometrium can be divided into subendometrial myometrium, which is called juxtazone, and outer myometrium. The subendometrial myometrium is involved in the preparation of the endometrium for implantation and uterine peristalsis, sperm transport, and hemostasis during menstruation. The uterine adenomyosis without subendometrial zone changes. This atypical adenomyosis often coexist with the severe endometriosis, and it is commonly localized at the outer myometrium without aberration of the subendometrial myometrium. The impact of adenomyosis in IVF treatment is controversial. The two studies showed a positive effect of prolonged down regulation on IVF outcome of women with adenomyosis, whereas another study reported a negative effect of adenomyosis on the final outcome of IVF treatment. The extrinsic adenomyosis has a characteristic that it is found mostly on the posterior wall and commonly coexisting with the pelvic endometriosis. When the adenomyotic tissue remained dense at the excised myometrium surface, the repair uterine wall could be lower in tensile strength, which may increase the risk of uterine rupture. This fact to be always kept in mind when you subject the patient for surgery for the adenomyosis. A nodule weighing more than 100 gram might be relatively risky as an indication for uterus sparing surgery for adenomyosis associated infertility. On the other hand, it is thought to be relatively safe in case of small adenomyosis that localize the intra or outer myometrium and keeps the subendometrial zone intact. Many times we come across total fertilization failure. Total fertilization failure, which is a failure of fertilization in all the oocytes, which occurs in 5 to 10% of the cycle in IVF and 2 to 3% of the cycle where ICSI is practiced. Normally, following ICSI, the human oocytes fail to fertilize in approximately 30% of the cases. So, meaning of that is, suppose if you have got 10 oocytes and if the 7 oocytes are fertilized, it is okay. But if it is less than that are fertilized, then it is definitely requires to be investigated. The fertilization failure in IVF is mostly related to sperm abnormalities, whereas in ICSI, the reason mostly lies in oocyte activation defects. If a couple experiences fertilization failure, the likelihood of recurrence in subsequent cycle is approximately 30%. The diminished ovarian reserve is a risk factor for fertilization failure. Although fertilization failure in one cycle does not preclude successful fertilization in another cycle. The prognosis may be more encouraging with increasing total number of retrieved oocytes and mature oocytes. So, anytime the fertilization failure occurs, a treatment protocol where the best response is anticipated should be selected for the new cycle. Now we will discuss about the surplus slow developing day 3 embryo. The surplus 4 cell embryos on day 3, which is obviously slow growing, displayed a lower blast rate. However, once the blastocyst is obtained, it has equivalent clinical outcome. So, our practice is the embryos that are developmentally lagging on the day 3 we observe in extended culture to increase the cumulative chances of successful pregnancy. The embryos with the optimal implantation potential on day 3 are characterized as having 7 or more blastomere, less than 20% embryo fragmentation, and absence of multinucleated blastomere. Whether you should be happy to get a blastocyst formation quickly or not. The blastocyst formation is associated with the early timing of first cleavage and increased day 3 cell numbers. The embryos that develop rapidly early on are more likely to continue developing at a rapid rate and form blastocysts. The more rapidly cleaving embryos on day 3 has traditionally been identified as a better embryo. But, however, embryos more than 9 cells are more likely to be aneuploidy compared with the embryos with 6 to 9 cells on day 3. Therefore, there may be an advantage to selecting the cleavage stage embryo with 6 to 9 cells over more rapidly dividing embryos. The high grade blastocyst arising from a rapidly developing embryos may be more likely to be aneuploidy than the blastocyst arising from 6 to 9 cell embryo SS 108 hours post SCG. So, to conclude, rapidly dividing embryo definitely forms a blastocyst, good quality blastocyst, but those blastocysts are most of the time aneuploidy. The ideal blastocysts which are derived from the embryos which were on day 3 between 6 to 9 cells gives a better euploid blastocyst. What is progesterone per follicle index and how it helps in taking decision of embryo transfer? The progesterone per follicle index, that is PFI, is a function of average amount of progesterone which is secreted from each follicle more than 14 millimeter in diameter. Unlike the serum progesterone level, it is inversely and linearly correlated with the clinical pregnancy rate. This relationship hold true for the entire cohort of normal responders and by type of pituitary suppression use GnRH agonist and antagonist protocol. So, which holds true for all spectrums of protocols and patients. The strong association between PFI and pregnancy rate emphasize the biological importance of progesterone secretion from each follicle as a potential marker of oocyte quality. A late follicular increase in total serum progesterone level is detrimental only and only if it results from an increase in the average progesterone secreted from each follicle and not if it results from the recruitment of additional follicles. The PFI enables clinician to differentiate these conditions and may facilitate a better decision making. The cycles with a low PFI can be continued confidently, whereas in case of high PFI, the cancellation should be considered. For example, only a relative high serum progesterone, that is more than 1.32 nanogram, was associated with the reduction in the likelihood of pregnancy. Below this threshold, the clinical pregnancy rates were unaffected. Whereas, if you consider PFI, with the PFI more than 0.34, no pregnancy was recorded. So, this is the utility of PFI. What is dual trigger? A low dose of SCG, that is 1000 to 1200, can be administered with the agonist as a dual trigger, or follow 36 hours later after retrieval. If it is given, then it acts as a luteal rescue. The concomitant dosing of SCG and agonist might be superior to either trigger alone in terms of oocyte maturity, blastocyst development, and IVF outcome.